This is a lecture about local anesthetic systemic toxicity, or LAST, which is an overdose of local anesthetic. So how does LAST happen? Well, it's an excessive plasma concentration of your local from IV injection inadvertently or from absorption from the surrounding tissues. You can reduce the chance of toxicity by reducing dosage, adding a vasoconstrictor, and implementing additional techniques such as aspiration before and during injection, as well as the use of ultrasound to visualize nearby vessels. IV administration is the fastest route of absorption for obvious reasons. The remaining routes follow in order as follows, with sub-Q being the slowest rate of absorption. Now, your brachial plexus absorption fits between your epidurals and your spinals in speed. This includes your interscalene shoulder blocks. The central nervous system is more sensitive to locals than the cardiovascular system, so CNS symptoms are seen first. The mild symptoms start with lightheadedness, tinnitus or ringing in the ears, circumoral and tongue numbness, a metallic taste in the mouth. Your moderate symptoms include visual disturbances, muscular twitching, agitation, confusion, and convulsions or seizures. Your severe symptoms include unconsciousness and coma, the most severe leading to respiratory failure, ventricular arrhythmias, and asystole. The asystole is caused by a combination of electrophysiologic and contractile dysfunction. Around 40% of LAST present as sudden, rapid onset seizures progressing to cardiac arrest. Timing of symptoms is variable. However, 50% of cases are in less than 1 minute. The immediate signs and symptoms suggest an IV injection with direct access to the brain. LAST can happen after 15 minutes, so it's important to closely monitor for 30 minutes post-injection. That means do not leave the bedside for at least 15 minutes post-block and make sure that you can hear your monitors and alarms. Let's discuss specifically epidurals in the obstetrical department. 2 of many physiological changes happen during pregnancy, but one to include reduced plasma concentrations of alpha-1 glycoprotein. This leads to less drug binding, therefore increased free fraction of the drug in the bloodstream, and also epidural venous engorgement. Those epidural veins get bigger, therefore giving us a bigger target for inadvertent IV puncture. The loading dose is given pretty quickly through the epidural, so there's accelerated infusion at the injection site. Plus, different providers and techniques and experience can also lead to increased chances of LAST. Now let's discuss the interscalene nerve block that's used to cover the brachial plexus. This is a common block that we do for surgeries down in the OR, any surgeries on the upper extremities, usually the shoulders. 20 mils, usually of ropivacaine, is injected into the interscalene groove. This is a highly vascular area due to close proximity of the vertebral artery, carotid artery, and internal jugular vein. The ultrasound is used to help visualize the structures and the specific location of the needle to try to prevent inadvertent IV injection. So some particular patients are at highest risk for LAST. Obstetrics, we already discussed, has the decreased alpha-1 glycoprotein in the enlarged epidural veins. You start mixing locals, such as the induction doses of lidocaine on a patient with an already completed nerve block. The tumescent we use in plastics has lidocaine in it. Thankfully, it's very dilute, but it is a high volume. Some of the lower extremity blocks require a local injection at more than one location, therefore requiring a higher volume. Pre-existing cardiovascular disease can make patients more prone to the arrhythmogenic and myocardial depressant effects of locals. The elderly have decreased muscle mass, so they should have a lower dose as well. Renal and hepatically compromised patients also have decreased metabolism and clearance of the locals. So, what's a safe dose of local anesthetic? Not many esters are used anymore. It's mostly the amine class of locals. Anytime you add epinephrine, it allows you to increase the dose of the local because the epi vasoconstricts at the tissue, therefore slowing the absorption, therefore minimizing toxicity and prolonging the duration of action. Bupivacaine and ropivacaine are our most commonly used locals. Bupivacaine is used in the spinals, while ropivacaine is used in epidurals and in the peripheral nerve blocks. Ropivacaine is safer because it's less cardiotoxic than bupivacaine. Your numbers are lidocaine is 5 milligrams per kilogram or 7 milligrams per kilogram with epi. Your bupivacaine is 2 milligrams plain or 3 milligrams with epi. And your ropivacaine is 3 milligrams per kilogram, and ropivacaine does not come with epinephrine. So what are some things you see us do to try to prevent LAST? Well, first of all, use the lowest effective dose. Don't give more if it's not necessary. You'll see us use a test dose when placing an epidural. This is epinephrine and local anesthetic combined. And we ask for signs and symptoms. Any ringing in the ears, funny sensation around your mouth, feel like you're sitting in a warm bath, racing heartbeat. Those are all signs that maybe we don't have the epidural in the right place. We have all of our monitors on when placing an epidural or a peripheral nerve block. Blood pressure, heart rate, EKG monitor, pulse ox. We use incremental injections, usually 5 mils, and we aspirate every 5 mils to try to assess for blood. Give individualized dosing based on weight that we already talked about. Most importantly, we are prepared. We have the treatment in-house. We also have continuing education for everyone. We have the proper equipment, which is the ultrasound, and we go through drills. And be vigilant. Assess for risk factors. Always be watching. So, what do you do if you think your patient is showing signs and symptoms of LAST? Well, first of all, call a rapid response. If an epidural infusion is running, stop it immediately. Your 3 pillars of treatment are seizure management, ACLS, and prompt lipid administration. You're going to find your lipid emulsion bag in the Pyxis under the word FAT, F-A-T. You give an initial bolus of 1.5 milligrams per kilogram, then start a continuous infusion of 0.25 mils per kilogram per minute. In your ACLS algorithm, you're going to want to decrease your epinephrine push doses. And you're going to avoid vasopressin, calcium channel blockers, beta blockers, more lidocaine for arrhythmias, and amiodarone. Your first-line treatment for seizures is your Versed. Don't give propofol because it can further compromise cardiovascular instability, and it does not provide sufficient lipid content for local anesthetic reabsorption. Please refer to this algorithm in your treatment for LAST.